Hello friends, welcome to my channel again. Today we are going to see how posterior wall blowout happen and what are its prevention and management techniques. First of all, I would like you to see this video. This is one patient with mucoid ACL and ACL debridement and reconstruction was done. As you can see here, after ACL debridement, this is how posterior wall is made, and you can see the small blowout posteriorly. Here, small blowout posteriorly of the femoral tunnel, and I would like you to remember this image, and we will come to this later on. Most of the data is taken from this article and some of the images too. And then these are the causes, most common causes of the femoral posterior wall blowout. First is the portal placement, then is degree of flexion of knee, then anatomical variations are there, and arthroscopic image distortion. We will discuss these one by one. First of all, there is portal placement. As I have already discussed in my video on femoral tunnel, that we have to make this portal, as you can see, this is the over the top position, as I already discussed in my previous video. So we have to make this adequately anteriorly from this over the top position so that the posterior wall blowout doesn't happen. So I will discuss this later, how to do that. Then is the degree of flexion of knee. So we normally make our entry here, starting position is here for the femoral tunnel. So as we flex the knee, our point will come here. So if we make this entry here only in extended position, the pin will come like this and posterior wall blowout will happen. But if we flex the knee, then the wire will come like this and our posterior wall blowout will not happen. So the less the degree of knee flexion, the more chances of the posterior wall blowout. Then there are some anatomical variation, the degree of sloping of the knee, in some knees intercondyle ridge is visible, sometimes not. So this can lead to posterior wall blowout in some patients. Then what are the prevention tips? First of all is the proper visualization of the soft tissue and the bony landmarks on the lateral femoral condyle. The first of all, when you are doing the ACL, you have to take out all of the soft tissue. Just remember it, I am stressing it, all of the soft tissue from the lateral condyle medial wall. So as you can see here, this is the lateral intercondylar ridge and then the lateral bifurcate ridge. This lateral intercondylar ridge, the ACL is inserted posterior to this ridge. And the two bundles, the posterior lateral and the anterior medial bundles, are separated by this lateral bifurcate ridge. But initially, when you are doing it in your initial 20-25 cases, you will not be able to see this clearly. But as you go on further in your surgeries, you will be able to appreciate this easily. So what we have to do is make your femoral footprint posterior to this lateral intercondylar ridge and over this lateral bifurcate ridge, but not posterior to that lateral bifurcate ridge. Then mark the area radius plus 2. What do you mean by that is, if you have to make 8 mm tunnel, 8 mm tunnel radius is 4 and 4 plus 2 equal to 6 mm. You have to come 6 mm interior, so you are not blowing the posterior wall out. Then there is the knee flexion should be around 120 degree. Why I am saying this is, as I have already discussed, the more you flex the knee, the more anterior your entry point will come. The more you flex the knee, the more anterior your entry point will come, and then you are able to easily make the tunnel. But beyond 120 degree, knee flexion is also acceptable, but just that it will make your tunnel short. Otherwise, regarding the posterior wall blowout, it is safe too. Then check through the medial portal. This is absolutely necessary if you are not using the offset. If you are not using femoral offset for making the femoral tunnel, first making the initial mark, then you have to check through the medial portal, and after drilling through the 4.5 mm drill bit, then again check through the medial portal that you are sufficiently anterior to the over the top. And if you are just if you have just started doing ACL surgeries, just use one femoral offset guide. This is one striker one, and with the flange, just place that flange over the top position, and you can just make the femoral guide here. No need to worry about the posterior wall here. Then what to do if the posterior wall blowout happens? First is continue with the planned fixation. This is done if your defect is less than 5 mm and you are using the endo button. As you have seen the first video in which the small posterior wall blowout happened, you can continue with planned fixation, that is endo button in that case, which we did. And the interference screw is absolutely contraindicated if there is a posterior wall blowout. Then there is suspensory cortical fixation. Suspensory cortical fixation, you can use a screw washer, and similarly you can open this small incision is given laterally over our exit site, and the threads are withdrawn, graft is pulled, and the screw is placed here just inferior and anterior to the our tunnel. It is placed anteriorly to just make the graft hug the anterior wall of the femoral tunnel, and inferiorly to prevent the irritation with the iliotibial band. And if we are also using the endo loop, the endo button, just place the loop around the washer and tighten the screw. Then there is the over the top position, and these are the just historical reference, and these were used initially. I would not like you to use these techniques, or this is just a passing reference. Then there is accessory anteromedial portal and diverging tunnel. What you can do is make one portal inferior and medial to the medial portal. Suppose our medial portal is here, medial portal is here. Make it inferior and more medial, accessory anteromedial portal. And with that, what you can do is just direct it divergingly anterior and lateral. Anterior and lateral to the previous tunnel. The tunnel will be a bit short, but that will prevent your posterior wall blowout further. Then there is the 2 incision technique. This means that gives small incision over the laterally over our exit site, and then you can use a ACL guide to make one femoral tunnel. This is one video I downloaded from the YouTube. So they will use the tibial guide here to make one tunnel 90° to the tunnel where the posterior blowout has happened. And this tunnel is made 10 mm posterior to the, as you can see here, using the tibial tunnel. They are using the tibial guide to make this tunnel. I'll just make small incision anterolaterally over the little femoral condyle, and then tunnel is made just 10 mm posterior to the mouth of the tunnel. Now the tunnel is being drilled, and then the edges of the tunnel are smoothened with their asper, as you can see here. And the rest of the procedure is same. The threads are withdrawn and the graft is passed. Now, what will be the take-home message here? So first of all, posterior wall blowout is an avoidable mistake. First, mark the tunnel position, then confirm the position through the anteromedial portal, and adequate knee flexion should be there to prevent the posterior wall blowout. And don't panic if blowout has happened. And if you are a beginner, use an offset guide to make the femoral tunnel. And screw and washer post is the safe in any condition if the posterior wall blowout has happened. So hope you like this video, and like, subscribe, share, comment. See you in next video. Thank you.